Welcome everyone to the American Academy of Pediatrics Coding Webinar Series. This webinar will focus on the COVID-19 pandemic and how it is impacting our coding. We do understand that there is a lot of anxiety surrounding the world that we are all facing, but by working together, we will get through this. This is a rapidly changing issue, and what we will be presenting today in this webinar is what we currently know. Please know that the AAP is aware of the rapidly changing environment that is related to the patient care that is brought on by this new pandemic. Patient care platforms have changed, which affects the way we report our healthcare services. The Academy is working hard to stay up to date on these rapidly changing rules and codes from both CPT and CMS to ensure that our members are informed. We are very grateful for our presenters today, because like most of you, they are dealing with COVID-19 in their work environment and on the home front. I would like to introduce our two speakers for this webinar. First up, we will have Dr. Jeff Linzer. Dr. Linzer is the Associate Medical Director for Compliance for the Emergency Pediatric Group, Division of Pediatric Emergency Medicine, Children's Healthcare of Atlanta, and Associate Professor in the Department of Pediatrics and Emergency Medicine at Emory University School of Medicine. Dr. Linzer has been a member of the American Academy of Pediatrics since 1987 and is active in the AAP section on emergency medicine and transport medicine. He is also a member of the AAP's Committee on Coding and Nomenclature and serves as the AAP's representative to the ICD-10-CM Editorial Advisory Board. Additionally, Dr. Linzer has taken on the role of the chair of the first ever topical advisory group as ICD undergoes its 11th revision. He currently still works on ICD-11 updates. Dr. Linzer is an expert in ICD guidelines and implementation and has been actively involved in the ICD-10-CM transition in the United States. Next, I am happy to introduce Dr. Linda Parsi. Dr. Parsi earned her medical degree in 1994 and completed her pediatric residency in 1997 from Baylor College of Medicine in Houston, Texas. She received her Master's of Business Administration in 2008 from UT San Antonio. She holds numerous certifications, including the Certified Medical Coder and Certified Medical Office Manager through Practice Management Institution, and is a Certified Pediatric Coder through the American Academy of Professional Coders. She is the current chair of the AAP's Coding Publications Editorial Advisory Board and sits on the AAP's Committee on Coding and Nomenclature. She has been in private practice since 1997 and has owned her own practice since 2004. She has presented talks at numerous pediatric conferences and webinars. Once again, we are very pleased to have both presenters here today, and now I will turn things over to Dr. Linzer.
Thank you very much, Becky. So as most of you are aware, the COVID-19 is a condition caused by the SARS-CoV-2 virus, and it's generally a respiratory disease, though we have been seeing other manifestations. The CDC website is the best up-to-date location to get information concerning more clinical findings and management of this current condition. But because the concerns and the way that this is being dealt with in the general public, there's a lot of fear out there. It really is coming down to we don't know what we don't know. And this is leading families to seek advice from their primary care provider as well as other specialists in dealing with this condition. The World Health Organization, which owns the International Classification of Diseases in the 10th edition, responded to the global pandemic by developing an emergency code specifically to track the COVID-19. WHO came up with two unique codes, a 07.1, which is used when the COVID-19 is confirmed by laboratory testing, and a U0.2, which is used when the diagnosis is made without confirmation or inconclusive laboratory testing. These codes are not applicable in the United States. This is what the WHO has come up with, but it is not what we're going to be doing here. Based on the ICD-10-CM coding guidance, we only use a code to identify that the condition has been determined to be present. The clinical modification in the United States for ICD-10 does not require any testing in order to make the diagnosis. The diagnosis is based on the highest level of clinical certainty. So beginning of April 1, the code U07.1 will be available when the diagnosis of COVID-19 is made by the physician or clinician, regardless of whether there's laboratory confirmation or not. This is part of the HIPAA transaction code set that payers are required to follow. Why do we do this? Again, because the coding rules in the United States do not require testing to make the diagnosis. And I think every physician who is listening to this talk at some point in their career and training knew some senior physician who could look at the patient, said they had XY condition, and was always right. They didn't need any testing. You don't necessarily need any testing. A brand new chapter is being added to the ICD-10-CM called Chapter 22, which is codes for special purposes. That is new and effective this April 1. And the new category of U07 emergency use codes has been developed. The new code U07.1 will be used to identify COVID-19, again, with or without testing. And then you are to use additional codes to identify other manifestations such as pneumonia. An excludes one note in ICD-10-CM means that two conditions are unlikely to exist at the same time. So if a patient had another coronavirus infection that was unspecified, you would not use that code, for example, if you were using the COVID-19, or if the coronavirus was the cause of a disease classified elsewhere in the B97 section of the code book, or if the patient had pneumonia due to SARS coronavirus as opposed to this particular version of the coronavirus. Until April 1, this is the interim guidance on how to code for patients that have been suspected or have the diagnosis of COVID-19. You would use the diagnosis terminology first, such as pneumonia or acute bronchospasm, acute bronchitis, acute respiratory distress syndrome, and then use the nonspecific other coronavirus as cause of the disease classified elsewhere. This will change on April 1, and we'll talk about that in just a second. If a patient comes in or a parent brings their child in because they're concerned that the patient may have been exposed to the coronavirus, it will depend whether they're symptomatic and will depend on the type of contact or potential contact that they may have had. The code Z03.818 is used for an evaluation of a patient with a suspected exposure to a biological agent that has been ruled out, and the code Z20.828 is used when there has been contact or suspected contact with a viral communicable disease. If the patients don't meet these type of categories, then you would code only for symptom and complaints such as cough, shortness of breath, or fever. Beginning April 1, the new diagnosis code will be the principal code. So the patient has pneumonia due to COVID, you'd use the new U07.1 COVID-19 code and then add other viral pneumonia, the J1289, as a contributing or secondary code. So as you can see from the first example, it's all flipped here, and the COVID-19 becomes the principal diagnosis. The exposure code and symptom and sign codes do not change. So let's look at a couple clinical scenarios that hopefully will help clarify some of these coding issues. So the mother brings her child in for testing because one of the daycare workers tested positive for COVID-19. But the child is completely asymptomatic and has no clinical findings. In this case, you're going to use the ICD-10-CM code of Z20.828, which is contact with or suspected exposure to a viral communicable disease. Patient has no signs or symptoms. and did not have any clinical presentation that would make you think they had the disease. Teenager comes in with symptoms concerning for COVID-19. The patient and the parents deny any known exposure. The patient is tested because of the symptoms, but the results are not available for at least 24 hours. And the physician decides to wait for the test results before making the diagnosis. So in this case, you're only going to use signs and symptoms that presented with the patient, in this case, cough and fever. Since the physician does not want to use the clinical certainty of a COVID infection being present, you would not then use a COVID-19 diagnosis code, and you would not use one of the suspected because there is not any known exposure. So you have a school-age child who does test positive for COVID-19. During the active phase of this condition, the patient is seen through telemedicine. And at the initial diagnosis, the patient was also diagnosed with an acute bronchospasm. Okay, so the diagnosis code for this encounter is going to be the COVID-19 code, the U07.1, as the principal code, and the J9801 for acute bronchospasm as the contributing code. And this would be held code effective April 1. Before April 1, it would be flipped. The J98.01 would be principal, and the B code for other coronavirus would be the contributing. So this is going to be the big difference on April 1st. In this clinical scenario, you have a worried mother who insists on a telemedicine service with the physician because the COVID-19 is in the community. Her baby's asymptomatic, and after review, the physician determines the child is well, has no clinical symptoms, and has no true or suspected exposure. So based on the information for this encounter, the physician has determined that the patient does not have COVID-19 and has ruled out the problem. So this would be an encounter for suspected exposure to other biological agents ruled out. Okay, so this code is used when you're sure there's not been any contact and the patient has no signs or symptoms. Documentation is going to be very important here. Again, clearly document the reason for the encounter, regardless of the format, whether it's telemedicine or face-to-face, telephone, or so on. Your encounter needs to have a clear diagnosis or clinical impression that fits ICD-10-CM terminology. An assessment is really important because this is what contributes to the medical decision making, and this is becoming more and more important in your reimbursement issues as we move forward. Using terms like possible, probable, and suspected are useful in the assessment, but other than certain codes where suspected is added, cannot be used as part of the diagnosis or clinical impression. And you should avoid using the term rule out in your assessment unless you're performing a specific test to rule out that condition. It's just one of those red flag terms that could cause problems down the road, and it's much easier to say on my differential, this is what I was worried about, this was what's possible, but I'm not concerned about it because of X, Y, and Z. And again, remember your diagnosis based on your clinical judgment. Again, let me emphasize, there's nothing in the coding guidelines that requires any sort of testing in order to make the diagnosis. And this is one of the reasons why the WHO code set will not be coming to the United States. And with that, I'd like to pass you on to my colleague, Dr. Parsi.
Thank you, Dr. Linzo. It was really excellent. Thank you. So now we have the ICD-10-CM codes, and now we're going to talk about how to code our work. So it's the code procedural terminology, CPT, HCPCS, and E&M services we'll be talking about. So just as a brief overview, remember every encounter with a physician that requires cognitive services is an evaluation and management service. So as a quick review, we have face-to-face E&M services in our offices with the problem-oriented or preventive services, our sick and well exams. We have telephone care. We have digital online E&M services. And we'll be talking more in detail about each of these. So nothing will change during this time. The documentation requirements are the same. The preventive medicine services, though, they still recommend that should be face-to-face in the office, as no allowances yet for telemedicine, but this could change. So in terms of telemedicine, especially with this COVID-19 going on, we've all have been affected, and we want to keep our patients safe. And so telemedicine has really become the front line of what we're doing now. But it's also very important to understand how to use that. So telemedicine is defined as a synchronous service. It's rendered in real time with interactive audio and video telecommunications system. That means that synchronous means in real time, meaning face-to-face, and you can see them and you can hear them. So the CPT and CMS each have their own list of codes that are reportable via telemedicine with some overlap. There's also a telemedicine resource as well that is also very valuable. When a telemedicine service takes place, that is report the appropriate face-to-face equivalent code. So for example, that would be exactly our E&M codes for the problem-oriented visit, which would be like the 99212, the 99215, or so we would be using those codes, whether it's key components or whether it's time-based. Exactly what we're using today, it would be exactly like you see them in your office. However, the place of service, though, code is going to be, instead of 11, which is we usually in our office, it's going to be a 02, telehealth. This is regardless of where the physician is located. So we've gotten questions about that. The physician can technically be at home, and it would be fine. Also importantly, to append the modifier at 95 or a modifier GT, and use this only when instructed by the payer, such as the Kansas Medicaid. This is a vignette for telemedicine visit. And again, it's very important that each physician determines what is going to be best for your own office and what are you comfortable with. There's no right or wrong answers. So there's different situations. So you determine what you feel is going to work for a telemedicine visit. So this is a mom and daughter. They're connected to their physician via live telemedicine. This could either be through your electronic medical record, or it can be another service as well too. The patient is established. The physician performs an E&M service with a detailed history and a moderate medical decision making. There is minimal exam elements documented. What I like to do is have the parent or the patient take their temperature and their weight at home. But then I also document that this was done by parent at home during the telemedicine visit, so that it's clear that where did this weight and temp come from. And based on the documentation for this established patient, 2 out of the 3 elements, this is a 99214. But let's say you spent 40 minutes on this patient. Of course, it's going to be face-to-face, so then you would just document your time, and that would be could be a 99215 as well. So you can, depending on what your highest level is, that is perfectly fine to do as long as everything is clear and documented. Also, too, even on your physical exam, if you hear them coughing, how they look like, or you can be commenting on those too. So some physicians tell me they have the patient get a flashlight, look in their throat. You can have them cough. So there's different things that you can do as long as you're comfortable with all that. Another vignette, a mom and daughter are connected to their physician via live telemedicine. The patient is established. During the encounter, the video service cuts out due to an issue, and we have definitely had these issues. The audio is still maintained. The physician performs an E&M service with a detailed history and a low medical decision making. There is minimal exam elements documented. Based on this documentation of the 2 to 3 elements, this is a 99213. Again, you can overwrite this with your time if you're passing this as well too with a 99214 or 15. Again, all documented. The service was started using the AV audiovisual and intended to be a true telemedicine service. So in good faith, it was started at that, but unfortunately, especially with everybody on the internet, everybody's at home, so we are having some slowdowns as well. So this is but it's perfectly fine to still use that code. Another vignette: an established patient with ADHD needs a refill on medication and is due for a follow-up. So this is a perfect example. The patient is stable, is doing well. Let's say it's been 3 months. And so prior to the service staff, what we like to do is to email the Vanderbilt out, a blank Vanderbilt, so it's HIPAA. And then during the encounter, an E&M service is based on time. So that took 20 minutes. So the Vanderbilt took roughly about 5 minutes to go over and score. Because you would report in 96127 for the Vanderbilt, technically this is not approved for a telemedicine service to use in 96127. However, if you can get that information back, like let's say they can fax it, or you can somehow get it through their portal, you could code the 96127. But if you don't have anything from them back, then we cannot technically code that. However, you can code our time that was spent reviewing that, and you can document that. So you can include the time spent in your E&M service or develop a HIPAA-compliant way to receive the instrument back, and now you can code the 96127. And no modifier 95 on the 96127. In this instance, the 99214 for the time is spent in counseling. Another vignette: an asthmatic patient requests a telemedicine service. She feels like her medication is not helping like it should. An ACT is also sent. You can emailing that blank one during the encounter. During the encounter, the physician walks through the ACT and her which is the asthma control test, and her symptoms. The asthma control test, the 96160, can be coded. So what I like to do is email it to them, and then I'm going through it, and they're reading it to me, and I'm documenting on my end what the scores were, and then I'm uploading that into my system. They could also, again, fax it. I wish I could, if you have a HIPAA compliant way for you to get that back through your portal, that's another option as well. So then you can import a 99213 with a modifier 95 added for the telemedicine visit. Possibly the modifier 25 could be needed as well too with the 96160, depending on your payer. And again, just to stress again, the 96160 is approved to use on the telemedicine. Another vignette is a neonatologist is asked to consult and see a mom in the outpatient setting. So let's say we're in the COVID-19, mom is pregnant, she's possibly high risk and does not want to be, she should be home. And so she's 32 and 47 weeks pregnant and fetal issues have developed. The neonatologist needs to arrange for a remote visit. What are our options and how are they coded? Ideally, this visit would be conducted through an audio-visual connection and a 99241 to 99245 with a modifier 95. If you try in good faith to do audio-visual, you should still code using the consult codes. Appropriate telephone care may not be appropriate because they require that the patient is established and the patient or parent initiates the visit. So these are so that's telemedicine. So now we're going to talk about other non-direct services. So we have telephone care. So this is very important to understand the differences. So the telephone care, and we're also going to talk about digital online E&M service. And this is mainly through the patient portal or email. So telephone care for physicians or advanced practitioners, which would be like nurse practitioners or PAs, these are based on time. And so very importantly, I'm just going to go over the definition. So the telephone and E&M, the evaluation management to a patient, parent, or guardian, not originating from a related E&M service, within the past week. Or you're not seeing, or if you're seeing them the next day. Then if you're meeting that criteria, you didn't see them the past week or you're not seeing them the next day, then you can use your telephone visits based on time. So that would be the 99441, 5 to 10 minutes, and 99442, 11 to 20 minutes, and 99443, 21 to 30 minutes. So very important to document and note what you talked about. and what's your diagnosis so that you can code it so that your ICD-10 code can match your CPT code. Also, too, just a quick little thing. Now, if you saw the patient maybe during the week, but now you're talking about a different problem, it's not related, then that would be different. So just be careful that it needs to be a related E&M service as well. Okay, so now we're talking about pretty much the same definition, but these would be non-physicians. Non-physician providers who may independently bill, such as physical therapists, speech, occupational, dietitians, psychologists, but again, not our clinical staff, which would be like medical assistants and RNs. Okay, so 98966, again, is 5 to 10 minutes, 98967, 11 to 20 minutes, and 98968, which is a 21 to 30 minutes. That should be a medical discussion. So, and again, it's the same thing. If you see them within the past week, or you're going to be seeing them the next day, if you're meeting that criteria, then you can use these codes. And again, same thing, we cannot have medical assistants or RNs billing for those telephone care codes. You cannot bill for telephone care if a face-to-face or telemedicine service was performed within the previous 7 days, same issue. The telemedicine service also counts as well. You cannot bill for telephone care if the call leads to a related E&M service, related. However, if it's unrelated, that would be different. And that needs to be clearly documented. Again, just a brief recap. We need to document total time spent with the parent or patient on the call. You will need to document what was discussed and like a diagnosis. For example, they had runny nose and cough. You might want to put, upper respiratory, URI, or cough, or reason for the encounter, just so it supports our code. No key elements need to be met, just time. But again, documenting the entire conversation. And then now the next thing we're going to talk about is digital online E&M service. So this is going to be a different category. So these are going to be more portal through our E&M service or our emails. The patient-initiated services with physicians or other qualified healthcare professionals, again, nurse practitioners or PAs, who are allowed to report an E&M service. The online digital E&M services require physician or other, they call it qualified healthcare professionals, evaluation, assessment, and management of the patient, and are not for the non-evaluative electronic communication of test results. Scheduling appointments or other communication does not include E&M. So basically, this is E&M. The patient initiates it. Patient must be established. The services must be initiated through a HIPAA-compliant secure platform. Again, like your portal through your electronic medical records. Reported once for the physicians or other QHPs, cumulative time during a 7-day period. So what that means is that, let's say the patient sends an email through the portal, and then the next day, the physician answers that, may take like a minute or 2 minutes. The next day, the patient responds, and then the physician responds back the following day. So all that time spent is in that week. So that's important to document your time as well. The 7-day period begins with the physician's or other QHP's initial personal review of the patient-generated inquiry. So it has to be done once we're looking at it. That's where the clock starts. The online digital E&M services require permanent documentation storage, electronic or hard copy of the encounter. So do not report these codes separately if the patient is seen within 7 days of the service. If within 7 days of initiating the digital online E&M service, you see the patient in office or telemedicine, you add the work to the E&M service and do not report separately. So basically, if they're coming in for that related problem, you're going to add that. You have to roll it into your evaluation management service that you see them in their office or the telemedicine. If it's a related problem within the 7 days. For the digital online e-learning service for physicians and advanced practitioners, so these are the codes. So 99421. So again, it's the online digital evaluation and management service for an established patient for up to 7 days. Cumulative time during that week is 5 to 10 minutes. 99422, 11 to 20 minutes, and 99423, 21 or more minutes. So the following codes are reported by non-physicians, so it's kind of the same thing as your telephone, who may independently bill, such as physical therapists, again, occupational, dietitians, psychologists, and again, not reported by your clinical staff. And those are the 98970, 5 to 10 days, 98971, 11 to 20 minutes, and 98972, 21 or more minutes. So one vignette on this, a patient who was seen on a regular basis for glucose checks is now home monitoring. So let's say this could be a diabetic patient. She wants to discuss some recent spikes with the doctor. Communication through the patient portal is performed over the course of 4 days. The doctor and patient are comfortable with the plan, and the patient does not need to be seen at this time. The total time spent is 23 minutes over the 4 days. The documentation reflects the total time and all the information shared, including the plan. The physician may report a 99423. However, if this was a registered dietitian who can independently bill, report a 98972 instead. So now we talk about testing. So if your facility is performing the COVID-19 testing, be familiar with the type of test and what codes are accepted. Most non-Medicare providers will accept the CPT code. However, check with your payer to ensure the code you're reporting is on this laboratory fee schedule. So basically, we have 3 things. So the CDC and non-CDC. So the U0001 is a CDC. It's a reported for coronavirus testing. The U0002 is a non-CDC lab test for the COVID-19. The 87635 is basically it's an infectious agent detection for the COVID. So this is if your office is not running the test for the COVID-19, then you do not need to report these codes. But that would be another test that we could do. If you are swabbing and sending out for testing from your office, and you're not doing it in your own office, you're just swabbing and sending out, then you would use the handling fee, the 99000. So respiratory procedures. So since with this COVID-19, we're moving away from nebulizers to meter-dose inhalers. So again, depending on your situation, you can, again, using your good judgment on what you can use. But this is a thought to help minimize possible spread. And again, use your good judgment. If you just have, one room and you just, you can, so you just decide. And to move away from the nebulizers to MDIs. While the CPT coding will not change, the supplies will. So if you use the administration of the MDI, your 94640, that is the same code that can be used for nebulizer treatments, can also be used for a meter-dose inhaler. Also, if you teach it to do a demonstration of either the nebulizer or meter-dose inhaler, you can use the 94664. Again, each CPT code does need documentation. Just make sure that you can support every code that you're using. So if you decide I'm going to use the MDI, then the albuterol code for that would be the J3535 through a meter-dose inhaler. And that does need the NDC code. And then your spacer, the A4627, is basically the air chamber with or without the mask. So it's either one. Some payers may want to use a different code, the S8100, which is basically the air chamber without the mask, or the S8101, which is the air chamber with the mask. So depending on your payer, if you do this, this may be a little tough because maybe I'm not sure we get to share the inhalers. So again, use your good judgment. It doesn't sound like a good idea. It's understood in theory, but probably better would be for them to bring their own inhaler in and their own aero chamber. But of course, we couldn't code for that because we didn't buy that. But so again, use your good judgment what your situation is in your office. And I'm going to turn this over to Becky, who will talk about modifiers.
Thank you so much, Dr. Parsi, for going through a lot of the bulk of the work that is really causing a lot of confusion for our members, and a lot of the scenarios we're seeing. Some things may seem a little odd or awkward or not what we're typically used to. But please know that everything we're presenting in this webinar has been brought to the AAP's attention, so we felt the need to make sure that our members are fully aware of what's going on in the real world, and of course then how to code for it. And so next, let's transition over to modifiers. Obviously, modifiers are still important, COVID or no COVID. We still need to use our modifiers and use them appropriately. We do have a couple we're probably not used to using so much. The first one is this CR modifier, and some of you may or may not be familiar with this. This was originally developed after the Katrina hurricane disaster and the fallout from all of that. It's still an active modifier and still usable. So CMS has decided that for Medicare patients under Part B, which is all of our outpatient physician services, to start using this modifier to be able to better track COVID services and coding services during the time of the pandemic. We are unclear at this time whether all payers will require this or how this is going to look, but we wanted to make you all aware. Again, we're getting questions on it, we're seeing it. We wanted you to be aware of what it was and what it is. The next is Modifier 95, which of course Dr. Parsi has mentioned throughout, and this is what we use on our approved telemedicine services. Both CPT and CMS have a list of approved telemedicine services. We have a sneaking suspicion that list is going to expand exponentially, but at this time, what is on those lists are appropriate to be done via telemedicine services, as well as being appended with Modifier 25. And again, this is for a patient who is seen for a live audiovisual E&M service. So this is the synchronous live audiovisual. Again, as we learn more, we will figure out what that means in the long run. But for right now, that's how we use the modifier. The GT modifier, people are also asking about. This was a modifier that was developed by CMS for telemedicine back several years ago, but CMS has stopped using it. They have decided that the 95 modifier is good with the place of service 02. However, some areas do want the modifier still, the GT modifier. We have learned that Kansas Medicaid and Blue Cross Blue Shield of Kansas, they both are requesting this GT modifier in lieu of the 95 modifier. We still have our 25 and 59. We cannot forget to use those and keep those in mind as we're still billing. Those rules have not changed, whether we're seeing the patient in the office or via some telemedicine mechanism, or a combination of both. We have some members who are doing some things via telemedicine and then bringing the patient in for a quick swab or a procedure. So in the case of, we have a patient who was received a telemedicine service. Upon the completion of the telemedicine service, the physician has decided to have the patient come in. In this case, they had to have a foreign body removed. So the 2199213 would be reported with Modifier 25 and Modifier 59. And then you would report your 10120, which is your foreign body removal, strictly for the office service, but you would not append Modifier 95 to that service. Again, 59, another tried and true modifier, used to indicate that two distinct non-E&M services took place. You're going to use that if, for an example, if you are doing the MDI or NEB administration in your office, and then this patient's going home for the first time with the MDI or a nebulizer, and you have to teach the mom or dad or guardian how to clean it, administer it, do all of that work. And it's a significant and separate service from the administration, so you're doing the demonstration or teaching on that front, and it's documented. You would report both codes, the 94640 as well as the 94664, and you would append Modifier 59 to the 94664. As this has been going on for about 2.5 weeks now, the Academy is putting together some FAQs, and we thought we'd share a few here. We do have a list of resources at the end where you're going to see all of our FAQs that we're getting in to make sure that we keep up to date on some of the FAQs being asked. So this one, we get a lot of questions about the 99050 and the 99051, which is our special services codes. This is what happens when office visits take place either on a weekend or an evening, or when your office is technically closed. At this point, we do not have a clear idea from CPT what they want to do. Our concern is that the code descriptors do say in office, and these services are not taking place in the office setting. However, we do understand that these services are being done in lieu of the office visit, so we don't feel it's inappropriate to ask the question of your payers or to even start using it and see how it's getting adjudicated. But at this time, CPT has not come up with clear-cut guidance on that. In addition, we don't really see any other applicable special services at this time. So that for right now, we're going to steer clear of using any special services codes until things change a little bit or we have clearer guidance from CPT. The next one we have is what happens when we have two different place of service codes, similar to our example earlier. What happens when we do part of the service on telemedicine and then the patient has to come in to complete the service. So each line item in a claim form can have its own place of service. So for the, let's say you're doing a 99213 via telemedicine, you would use place of service 2. And then if you're doing whatever, strep screen, foreign body removal, something that has to be done visually face-to-face, we're saying use place of service 11 for that if it's in your office as an example. So you can have more than one place of service per claim form. We know everything is rapidly evolving. Like I said, the Academy is trying to stay ahead of it as much as possible. Again, the AMA, who does own CPT, is advising that telemedicine services do not require the video portion in order to appropriately report. However, the Academy is in agreement with that. At this point, we do feel that that is appropriate given the current state. However, we do not have a clear sense from CMS or payers if they are on board, which is why at this time we would caution. However, this is still all rapidly evolving. Another area is we are advocating to have preventive medicine services included as part of telemedicine. As it stands right now, preventive medicine services are not part of telemedicine. The Academy is going to advocate for that, plus many other services that we feel can be done in the telemedicine realm, at least during this pandemic. Again, expansion of coverage in general, things that payers didn't cover before, non-face-to-face services, telephone calls, digital online E&M, anything of that nature that they claimed before could have been done in the office. Well, we're seeing that that's just not the case. So again, the Academy is working very hard to move all this forward. The Academy is advocating on 3 fronts currently. We are working on the federal level, state, as in the Medicaid in your state, and private payers. The one thing we're also talking about is telemedicine parity in all states. That's one of the other areas that our groups are working on. So please know that the Academy does have COVID resources, both clinical, which can be found right on the Academy's homepage, as well as coding information. We are pretty much updating our coding information almost daily. And that's going to be at the aap.org/coding. We urge you to bookmark that and visit it as often as possible. We updated it today. We'll be updating it again on Monday. We are including resources, questions from our members. So please, if there's something you're questioning, share it with us so that everyone can learn from it. And as always, the Academy does have the coding hotline. We are opening that up also for COVID questions. The Academy does have, though, a dedicated COVID email. So for any questions not related to coding, or if you want to ask a bunch of questions together related to coding, feel free to email the COVID-19@aap.org. We have dedicated staff who are working very hard on getting back to members as quickly as possible and working with the appropriate staff to get your questions answered for all things COVID. There are some external resources we urge you to look at on the CMS telehealth. Again, this is updated pretty frequently as well. And of course, the ICD-10-CM, and it's the National Center for Healthcare Statistics, so NCHS. Please consider visiting their site as well. Once again, we want to thank everyone for being part of this webinar and to extend our sincere gratitude to both Dr. Linzer and Dr. Parsi, as well as our staff, Caitlin, who was here to help us through all of this. So this is a lot of work, a lot of things going into it, but the Academy is going to be here, and we will all get through this. So thank you all again, and take care.